Amin.
Ladies and gentlemen, good morning to you. First, I would like to say that I presented some of my research in meetings sponsored by KCI in the past. The abdomen is open, as Ian said, so what to do next? What to do? There are different methods that have been used over the years for managing the open abdomen. They're all called temporary abdominal closure systems, known as TAC. The simplest one is just packing the abdomen. It's the earliest method documented in the literature. Pagoda bag, we know it very well. It's simple and easy, cheap, available all the time. Surgeons tried different meshes over the years, non-absorbable to start with, and then different absorbable meshes, and then recently biological meshes if the abdomen is clean. In 1990, Whitman suggested a leaf of mesh suture to each side of the abdominal wall. They overlap in the midline with Velcro. They can be tightened or loosened according to the reduction in the abdominal swelling without need to go back to theater. Barker from Tennessee in 1995 described this vac pack system, which is like the sandwich system, a fenestrated, basically non-adherent sheet covering the abdominal content, moist towels on top, and then drains attached to wall suction, and airtight seal covering the wound after this. In 2002, Miller modified this technique. He used the black foam invented or popularized by KCI for superficial wounds, and used the VAC machine from KCI. And following this, they popularized the VAC abdominal dressing system, which is commercially available. As we heard earlier, the outcome of the open abdomen, there are two outcomes. Either the abdomen will be closed, called delayed primary closure, or there's a planned ventral hernia. So how do we evaluate these different temporary abdominal closure systems? Well, of course, mortality is the most important outcome. Is the patient alive or dead? Now, getting delayed primary closure, of course, is very important, because if we don't, then the patient will need later reconstruction, which is very difficult. But of course, there's a big price that we have to avoid, mainly fistula formation, that the patient, again, will have to be in hospital for months for this, with a high morbidity and mortality, and residual abscess that require further laparotomy or drainage. So, where do we go? We have to look at the literature to see where is the evidence. Now, I'll go through some studies. This study from Italy compared a group of patients who used NPWT recently with another historical group where he used Pagoda bag. The mortality appeared to be less in the NPWT series, but of course the difference was not significant because the number is very small. This is a good paper from Sweden, 4 centers, 111 patients, mixed group of patients, sepsis, trauma, vascular, fistula rate of 7.2%, delayed primary closure, very respectable, 76%, with a mortality of 30%. Here they use a combination of mesh and NPWT. The only randomized study in the literature that was completed is by B. et al. From Tennessee, and they compared the group of patients where they used absorbable mesh with another group of patients where they used NPWT. The NPWT is a combination of VAC pack and VAC from KCI. And the fistula rate was 21% compared to 5% in the mesh group. That, again, was not statistically significant, but of course, the high fistula rate is alarming. Anderson et al. Recently, again, showed a fistula rate of 31% in an open abdomen, which was managed with different types of TAC systems. Rao et al. From Leeds, again, showed a fistula rate of 20% and a mortality rate of 34% in their patients. Again, 29 patients in this study. Trevelyan and Carlson from Manchester, of course, noted that a large number of patients had been referred to them with fistula after having NPWT used. So, where do we go from here? Well, let's try to pull these all these evidence together and see can we get a review, a proper systematic review of the literature. But of course, there's a lot of difficulties with that. Of course, as Ian said, there are two different really group of patients, early group and late group, and most of the studies include both of them. Meshes, do you group them as one group, or you analyze them separately? NPWT, do you use PAC and VAC separately or together? Particularly recently, Barker started to use his black foam of KCI instead of the towels, as he said earlier. So the difference between the two groups had been blurred. Again, there's a lot of technical variations mentioned in the literature. If you use a mesh and NPWT, how do you classify this group of patients? So a lot of problems. Having said that, there are two recent reviews, one of them from Hinsbroek from Holland, 57 series included up to 2007, and a most recent one by Quinn et al. From our group, 117 case series. When you look at Hinsbroek, basically he suggested that the VAC therapy and Whitman patch give the best outcome with a low fistula rate and the best closure rate. When we look at our own series, again, it's the same thing. We put the NPWT all together. Again, the closure rate is 57% and a fistula rate of 7%. Whitman patch, again, gives very good results. Again, when we try to look just at the trauma series, it's very difficult because there's only 25 series out of those 117. Again, Whitman patch and NPWT appear to give you the best maybe outcome, low fistula rate, and a high closure rate. When it comes to peritonitis, the first striking thing is that NPWT group is the only group of patients where you can find more than 100 patients. And the closure rate is 44%, but the fistula rate when our analysis turned up to be 15.6%. So, of course, that's a high fistula rate. Over 50% of the study come from American institutions, and that's very important because maybe the way they manage patients there is a bit differently than us. There are more trauma cases there than in our case series. 45% included heterogeneous group of patients, which are very difficult to analyze. And again, disappointing to see the small number of patients in the peritonitis group. These results suggest that Whitman patch and NPWT are associated with the highest delayed primary closure, the lowest mortality, and in our review, high fistula rate was noted in peritonitis series with NPWT use. Again, I would like to say that Whitman patch, most of the studies are published from his group, and very, very few studies come from elsewhere. But however, these results should be interpreted with caution because their case mix is different. Early series contain more pancreatitis and peritonitis, while the late series contain more trauma. Again, improvement in critical care, invasive radiology, nutritional support may have led to a reduction in mortality in recent series. So it's unfair to compare series from the 80s to those of 2005 or 6. Again, series from specialist center do not really reflect what's happening in the ground. Open abdomen is considered a failure, and none of us like to report the failure. So the small series are not there. All come from big centers where maybe they are more used to using the open abdomen. Again, there's a complete lack of well-designed studies. Most of them are retrospective, and there are only 2 randomized studies, 1 completed and 1 was not abandoned. So when we look at a patient like this, very difficult, 6-hour operation, external obstruction with a big incisional hernia. He had previously abdominal perineal resection, so what to do? Had to take him back to theater, excise the abdominal wall, and now 10 days later, although NPWT 10 days, this is the result. So what to do here? Very difficult. Another patient, subtotal colectomy 10 days earlier for an emergency perforated colon, again doing well. 10 days later, down to ITU, inotropes, ventilated, CT scan, free fluid and gas. You take him to theater, abdomen is dirty. This is at the second look afterwards, still, it's a bit cleaner than what it was, but the patient is still on a ventilator, not well. So you close part of the abdomen and put the vac inside, the abdominal dressing inside. And then third look, much cleaner, much better. We closed it. So this is the first one, is what Ian refers to as the chronic patient. The second one is the one who you can close him and you get a good result. So the management of open abdomen is complex and difficult. The ideal TAC should allow a second look, control exudate, improves the chances of delayed primary closure, and acceptable complication rate. If closure is not possible and the abdomen is clean, an absorbable mesh should be considered, particularly if there is little omentum to protect the gut. And I hope now Hannah will be able to tell us about the results and what to use for the open abdomen and what's been used in this country. Thank you very much indeed.